This is the case of a 21-year-old man who presents with 4 months leg weakness, numbness from groin to toes, and mild back pain. Patient also had intermittent fevers and night sweats for the last month. MRI revealed paravertebral abscess from T7 to T11 compressing the spinal cord. The neurosurgery team performed a decompressive laminectomy, abscess drainage, and vertebrectomy at T9 resulting in a spinal defect. So the problem list here is a 21-year-old male presenting with worsening lower extremity weakness and numbness. The patient also had intermittent fevers and night sweats for the last month. MRI revealed thoracic paravertebral abscess compressing the spinal cord. The patient underwent decompressive laminectomy, abscess drainage, and T9 vertebrectomy requiring spinal reconstruction. So how would you face the case? Option A, bone graft. Option B, free fibula, free flap. The votes are in and you chose B.
Hello, my name is Dr. Alexander Mericli, and I am a board-certified plastic surgeon specializing in microvascular reconstruction. The authors describe a 21-year-old man who presented to their facility with bilateral lower extremity weakness, numbness, and back pain, as well as a history of intermittent fevers and night sweats. Imaging revealed a large paravertebral abscess and epidural abscess from T7 to T11, as well as cord compression. Tuberculosis spondylitis was suspected given his presentation, and he was taken to the operating room urgently for a decompressive laminectomy, posterior spinal instrumentation infusion, and a partial T9 vertebrectomy. A 2.5 centimeter free fibula flap was used to reconstruct the partial vertebrectomy defect. The patient went on to heal, regained much of his neurologic faculties, and demonstrated union at the free fibula flap at approximately 3 months post-op. I'd like to congratulate the authors on a successful result and a well-written case report. Now, as a plastic surgeon that has a substantial experience at doing free tissue transfer for the spine and pelvis, I have a number of thoughts related to this case. First off, plastic surgery dogma states that a bone gap of less than 6 centimeters does not require a free vascularized bone flap for reconstruction. Spine surgery literature is a defect length of 4.5 centimeters for vascularized bony reconstruction. However, in surgical sites where the wound bed is compromised by either past or future radiation therapy or infection, it's very unlikely that a non-vascularized bone graft will heal effectively. Therefore, for situations like this, I err on the side of caution, and I'm much more likely to provide a vascularized bone graft for reconstruction of even small defects. Now, that being said, a partial vertebrectomy defect doesn't typically require a free bone flap reconstruction. A full vertebrectomy defect does require the structural integrity imparted by a free fibula flap, but for a partial vertebrectomy defect, the authors could have also considered a pedicled vascularized rib flap. This could provide the same advantages of vascularized bone while at the same time sparing the patient the donor site morbidity and additional incision required for a free fibula flap, as well as the necessity for microvascular anastomosis.